For watching Medical Sociology by Jordan Hildebrand. Medical sociology is about how humans handle issues of health, illness, and healthcare for sick and healthy people. A medical sociologist will study the physical, mental, and social impacts of health and illness. Some of the major topics for medical sociologists today include the relationship between the doctor and the patient, the structure and socioeconomics of healthcare, the cultural impacts on disease and wellness, and the social construction of health. When we are referring to the socioeconomics of healthcare, one major topic is the racial and income disparities in healthcare and in health outcomes. For example, the COVID-19 mortality for Black Americans in Chicago is disproportionately high. Blacks and whites each make up 1/3 of Chicago residents, but Black Americans have accounted for 45% of deaths due to COVID-19, compared to white Americans at 19%. The number of deaths per 100,000 was highest for Blacks at 107, and lowest for whites at 40 deaths per 100,000. Some of the proposed explanations for these disparities include crowded housing, jobs not allowing for social distancing, and less access to healthcare. From the perspective of a conflict theorist, we might look at how white privilege is embedded in our healthcare system. We want to identify healthcare inequalities and find ways to counter them. Sociologists Peter Conrad and Kristen Barker break down what's happened in medical sociology over the last 50 years into 3 categories: the cultural meaning of illness, the social construction of the illness experience, and the social construction of medical knowledge. Now, we'll dive deeper into each of these categories. Conrad and Barker's first category is the cultural meaning of illness. A culture may stigmatize an illness, which affects how the patient perceives themselves and how they're treated. The patient may not seek treatment if they believe they have an illness that is highly stigmatized. Additionally, providers may discriminate against such patients, and the facilities for them can be substandard. Sociologist Adina Nack's qualitative research on women's experience and the stigma around incurable sexually transmitted diseases has taught us that significant others greatly influence a woman's self-evaluation after receiving her diagnosis. The physician is the first significant person she is in contact with. 2/3 of women reported they were not satisfied with their doctor's bedside manner, and those interactions reinforced the woman's ideas that their bodies were permanently ruined. Nack discusses the immoral patient stage women go through following their diagnosis, where they experience shame and identity dilemmas. This is partly because STDs have this stereotype that only bad or promiscuous girls get them, which Nack proves is not true. This idea is reinforced by bad bedside manner, and it is made worse by the fact that no formal sex education provides guidance on how to live with incurable STDs. From a conflict theorist perspective, I want to point out the STD stigma was started as early as the 1800s by male medical practitioners with sexist moral agendas. But still today, women face the double standard. Our culture has historically valued virgin women, and those who contract STDs are mislabeled as dirty and overall less desirable than an STD-free woman. Men, on the other hand, are permitted to be promiscuous. A conflict theorist would dive deeper into these inequalities and confront them. Another major theme in this category is contested illnesses. Contested illnesses are those that have been questioned or are questionable. So, one physician may view the illness as having a legitimate physiological cause, while another thinks it's all in the patient's head. So treatments will vary. As such, patient outcomes will also vary. Conrad and Barker's second category is the social construction of the illness experience. This is based on the idea that reality is socially constructed, and how an illness is perceived is also socially constructed. This affects how the patient reveals their illness and how they change their lifestyle to cope with their illness. Some widespread diseases like AIDS and cancer have cultural markers that have changed over time. These markers shape how the individual perceives and handles their disease. Obesity is a relatively new health concern that's more common in high-income nations. It may be perceived differently across cultures, which will shape how that patient views themselves and their lifestyle. Individual personality also plays a role in the illness experience. While one patient may perceive their disease as limiting their life and their social circle, another patient may expand their activities and groups to find new people they can relate to. Conrad and Barker's third category is the social construction of medical knowledge. While we like to think of science as objective and based on numbers, we must also realize that nothing produced by humans is totally objective. Physicians acquire their knowledge from scientific journals, but even these research articles are written and interpreted by humans. Our cultures and views are embedded in this information. Being such, medical knowledge can reflect and reproduce inequalities in gender, class, and ethnicity. A conflict theorist might be interested in how our culture created these inequalities to begin with and how they are perpetuated through new medical knowledge. This last slide is just literature cited, and thank you for watching.